All right, so inflammatory bowel disease. All right, so this we're talking about irritable bowel syndrome. It's not really inflammatory, but it kind of is. It's not, but really what is truly inflammatory is ulcerative colitis and Crohn's disease. All right, so IBS has two varieties primarily. Sometimes there's a mixed version where you always are going to the bathroom with diarrhea, or you have pain with bowel movements.
If you are wise, you'll listen to me. What do you do when you're pooping all day? Got diarrhea, but that is okay. I do not know why I sing about poo. It just seems that that's what I do. I'm gonna take a poopy now.
All right, IBS. So IBS is just too much pooping, diarrhea, tachypoopia, or it is constipation variety. All right, so we have constipation variety and we have diarrhea variety. All right, so they're called IBS-D for diarrhea and IBS-C for constipation. Women are more likely to get it than men. It's also associated with menses. And it's been highly underdiagnosed, and now it's getting a lot more traction, kind of like fibromyalgia. But there's really no known cause. There are some theories. It's basically the enteral nervous system. You have a CNS, a PNS, a ANS, an SNS. You also have an ENS, which is your enteric nervous system. So the ENS is its own brain. Your GI tract has its own brain that can increase or decrease speed. And this is what's happening. It increases speed, causing tachypoopia, or it decreases speed, causing constipation, bradypoopia. All right. So we have different varieties of. We have a hypersensitive enteral nervous system. All right, so intestinal inflammation has been indicated, but they do biopsies, and really there's nothing like firm that they can identify that they can target. So, but they do see that this happens usually after a gastroenteritis or after an inflammatory bout. Oftentimes there's food sensitivities. So there's gluten sensitivities, there's carbohydrate, lactose sensitivities that put people at higher risk for IBS. There's genetic reasons, and also psychosocial. So it has to be addressed that we might start antidepressants or anxiety meds to after we've tried other medications to slow down or speed up the GI tract based on which variety they have, and also we have medications that will blunt the pain response. And the cool thing about antidepressants, besides being antidepressants, is they also abate pain signals in the periphery. So yes, they work internally in the brain, the CNS, to reduce depression, but also they work peripherally to reduce the pain signals, the pain inputs. Okay, so we have bowel motility issues. Okay, so we got colic. What is colic? Pain that comes in waves, right? It's all of a sudden, then it goes away. It's all of a sudden, and it goes away, right? They have a lot of abdominal discomfort, a lot of bloating, and they get a lot of pain that usually goes away when they defecate. Okay, so again, there are three types, technically just two. We got constipation variety, diarrhea variety, and then we have a multimodal one where it's both. They go between them. And then there's unclassified where they can't really figure it out. Basically, if you were to track your poops and you were to figure out what percentage of them were diarrhea and what percentage were constipation, you yourself can diagnose whether you have IBS-C or IBS-D. So if 25% of your poops are diarrhea-like, then they are IBS-D. If it's 25% are constipatory, then it's going to be IBS-C. Okay, and you do base that on the Bristol stool chart, right, which is 1 to 7 grade, right? What's a good Bristol? What's a good poop? Like an all-star, 3-star Yelp review poop. There's a site called ratemypoop.com. You can Google if you want. So what's a good Bristol stool poop? What's an ideal poop? Pencil shaped? Too dirty? No, it's about a 4 or 5, right? So it's smooth, but not too smooth, not too liquidy, not too hard, smooth and snake-like. All right, so that is what a good poop should be. If it is too poopy if it's too loose or too hard, then you are hitting the constipation side or the diarrhea side. And with IBS, they have this all the time, or they could have a mix, right? All right, so what else? So general symptoms, usually have this for like 6 months. And then they come, it's a very, very common complaint from the GI doctor's office. They come in, they've had this pain, and it is, they could have, they don't want to eat because they don't want all this bloating and abdominal pain. It's usually left lower quadrant because that's a tight area, right? That's a narrow lumen, so we're high risk down there. But it's very, very non-specific, like we said. So what we do have to look for is it something else that's concerning? Like, is it colon cancer? Is it diverticulitis? Is it something that's maybe like Crohn's disease or ulcerative colitis? So we have to think about those things. So if they have like sudden changes, like you don't all of a sudden have diarrhea for a week, right? That's not a thing. It has to be there for, they say, at least 3 months, okay? But they got weight loss. You don't get weight loss with this disease, right? With IBS, right? You're still eating. You may not want to eat, but you still are eating, still are taking in nutrients. With like inflammatory bowel disease, when we talk about ulcerative colitis and Crohn's disease, they get malnourished, right? Especially Crohn's disease patients. So nighttime pain is also associated with inflammatory bowel diseases, not IBS, okay? And bloody stools. You never have bloody stools with IBS. That's not a thing, right? IBS is just a change in the pattern of stooling, okay? So this is showing the difference between the pain between colorectal cancer versus, and also the stool habits and characteristics, right? Between Crohn's disease, ulcerative colitis versus colon cancer versus irritable bowel syndrome, right? They don't have weight loss in irritable bowel syndrome. They don't have GI bleed, right? It's not just diarrhea at nighttime, right? It's not a recent onset of diarrhea or constipation, okay? So that's how they identify someone has IBS. There's no diagnostic tests. You can't go to colonoscopy or an EGD and say, whoop, look at that, you got IBS. It's all based on symptoms. All right, what is this? Oh, it's not working. Anyways, all right, so we have these are your different IBS varieties and symptoms. All right, so IBS treatment goals. What do we want to do? We want to make sure that they are controlling the pain. So on the bottom right there, we have IBS-C, so that's the constipation variety. So in the constipation variety, we want to increase the speed or the peristalsis or the transit time inside the GI tract, right? And IBS-D in light green there, we are going to slow it down, right? And at the bottom 3 right there for pain control, like I said, antidepressants, SSRIs, and TCAs, those guys can be indicated to not only fix depressive and mental symptoms, but also they have pain control properties, okay? But that's pharmacological. So going back to non-pharmacological, we can do dietary recommendations. We can do a high fiber diet. And this is shown the most, and blue is the most efficient, most evidence, and also peppermint has been most efficient. But what's peppermint? What else? We talked about peppermint earlier. What is that bad for? For GERD, it reduces the LES, right? It relaxes that lower esophageal sphincter. So just gotta be cautious with that. But either way, peppermint actually shows that it's going to increase motility. So it's actually great for someone who has IBS D or C. C, right? So when it's constipation, we want to increase motility. All right, they should get a food diary to make sure they don't have like celiac disease. It's like, hey, you're eating dairy all the time. You notice you might be lactose intolerant, right? So let's try to cut that out, right? But Taco Bell's so good. Anyways, we got a low FODMAP diet, and it's probably the most confusing. I haven't found a good mnemonic for FODMAP, but FODMAP are carbohydrates that are poorly absorbed, and where sugar goes, water goes, right? Just like where sodium goes, water goes. Where sugar goes, water goes. So you're going to get diarrhea because all the water's going to go in the GI tract, and it's going to increase peristalsis, right? So we want a low FODMAP diet. We want to reduce those little short carbs, short-chained carbs, right? FODMAP stands for fermentable, oligo, and dimonosaccharides and polyols, which rolls off the tongue. Anyways, FODMAPs. So you want to make sure that they are, they should restrict their diet, have a food diary, so they are identifying if there's something that is in particular causing a diarrhea episode, most likely, right? So fructose, for instance, in apples, pears, and mangoes, we're going to do like a celiac diet. We're going to avoid wheat if possible, because that might be causing them to have these symptoms. Gas-forming foods, they stretch the GI tract and cause pain. So we're going to limit those as well. So cabbage, for instance. We have things that are like broccoli, cruciferous vegetables, right? Things that have like lactose. The bacteria in your stomach and their large intestine are going to break down the lactose and cause a excessive gas, right? So what else? So alternative therapies. So we talked about controlling mental health. So cognitive behavioral therapy, CBT, can be something. Acupuncture, hypnosis, stress could be an important cause of IBS. So we want to make sure that we are addressing that if we can. Probiotics to supplement the good bacteria. Maybe they have their GI biome is not ideal, right? And herbal medicines. So peppermint is shown the most evidence, but there's other things that can be anti-inflammatory, anti-spasmodic, which could cause some pain, right? Ginger tea, chamomile tea. Oh, there's a good, what's the chamomile? I can't think of the joke anyways. We have chamomile tea, we have other things that can help the patient with IBS. And again, these medications right here, all I want you to do is identify them if they are IBS or IBC. I don't want you don't have to know the side effects, all the nursing considerations. I really just want you to identify, is this a drug for IBS, C, or IBS in general, and is it a drug that is going to be for the diarrhea type or the constipation type? Okay. So pharmacologic treatment, again, it's working on these, it's working on either increasing GI motility or decreasing GI motility, right? It's like Miralax, like we mentioned, is just a fancy polyethylene glycol that's basically go lightly, right? It's going to pull fluid because it's a carbohydrate. It's going to pull fluid in the GI tract, and it's going to make it increase peristalsis, right? Next one is linaclotide. That's going to increase GI secretions and increase GI motility. We have ones that are like opiate-like, right? So opiate agonists. So opiates do what to the GI tract? They slow it down. These are opiate agonists that don't have pain control. They just bind to the opiate receptors in the GI tract and slow it down. Okay? So then we got some serotonin agents that are going to slow it down or speed it up. All right, so inflammatory bowel disease. This is our last section. So inflammatory bowel disease, we have two varieties. We have Crohn's and UC, or ulcerative colitis. So in the top left there is what are called not luminal, what's I'm looking for? I forgot it, not intestine, but they are outside the GI tract. They are symptoms that both Crohn's and ulcerative colitis can cause. Right? These are things that this inflammatory process, it's an autoimmune disease, and it's attacking the GI tract, and it's not like because of H. pylori or C. diff. It's just an autoimmune attack against the GI tract. And that autoimmune response can spread through the whole body and cause a lot of problems. Okay, so we'll talk about Crohn's disease and ulcerative colitis. Colitis tells you it is in the colon, right? So that's only where it's at. Whereas Crohn's disease technically could be anywhere in the GI tract. It can overlap with the colon, or it can go all the way up to the esophagus if it really wanted to. But most commonly, for playing Vegas odds, it's going to be right here. It's right there in the cecum, in the large intestine. Sorry, the ileum and the cecum, right down there. Small intestine and large intestine. All right, so IBD, not IBS, but IBD. All right, inflammatory bowel disease. All right, so we have two varieties. I've color-coded them for you. You got Crohn's disease in yellow and ulcerative colitis in blue. All right, so extraintestinal symptoms, that's what I was trying to remember. So it's an inflammatory bowel disease, so your bowel is inflamed, on fire, and we got to stop the inflammatory process somehow with medications. And the other piece is we have extraintestinal symptoms. We have symptoms outside the intestines that are causing problems, right? U.S. has the highest incidence. It's bimodal. It happens in young people and old people. Ashkenazi Jews are at risk, right? European descent. All right, causes are really unknown. It's conceived to be genetic, like an overactive immune system. Usually it's an autoimmune process. So something triggered your white blood cells to start attacking your GI tract. And when it attacks the GI tract, it's going to damage it and damage it and damage it and make it so it is leaky. So it's leaky for bacteria to leak across, and then you're going to overdo it. You're going to attack this inflammation. You're going to like the sledgehammer for the nail, right? It's going to really overdo it, and it's going to inflame the whole GI tract. And ulcerative colitis, again, we're located where? Just in the colon, whereas Crohn's disease is going to be, it could be anywhere, but it's primarily the ileum and the cecum. That's primarily where it's at, right? It's going to inflame the whole colon, and it's going to cause breakdown and bleeding, and it's going to cause diarrhea because what do you need? How do you absorb stuff? It has to go from point A to point B. It has to go from the GI tract into the bloodstream. And if your GI tract is all inflamed and can't absorb, you can't absorb glucose, so glucose stays in the GI tract, and water goes into the GI tract, you have diarrhea. So both these guys have diarrhea. Both of them have bleeding. Ulcerative colitis is really, really high for bleeding. So we'll point out the differences, right? So an overactive immune system, right? Inflammation is also interfering with absorption of things. So you're not able to absorb in the colon. Really, all you got to absorb is what? Water. So that's why ulcerative colitis has a lot of diarrhea. Compared to Crohn's disease is in the ileum. Remember we mentioned before in the distant past about ileum? And it's responsible for absorbing B12, right? So B12 is absorbed there. Folate is absorbed there. A, D, E, and K vitamins are absorbed there. So we'll point that out. So you're going to be malnourished with Crohn's disease, for instance. Okay? So you're going to get a lot of diarrhea, a lot of weight loss. Because of ulceration, so the whole GI tract will be ulcerated. So when we do a colonoscopy, we're going to see unique signs for ulcerative colitis and unique signs for Crohn's disease. They're able to be differentiated on a colonoscopy, and that's going to tell them which medications to start them on. Okay, and then bacteria is going to translocate, and it's going to translocate into the bloodstream and go anywhere, causing problems. Right, go to the eyeballs and cause uveitis, right, inflammation of the eyeballs. Okay, so extraintestinal manifestations, there's a whole bunch of them. All right, so Crohn's in yellow. So again, it can affect any portion of the GI tract, but it likes to take up shop in the colon and the distal ileum. And here's the example of things that are absorbed in the ileum. We got folate and vitamin B12, right? We have vitamin A, D, E, and K are activated there, but also absorbed down here, right? So we're going to be deficient in vitamins and minerals and such. So Crohn's disease is transmural. So mural means wall. So it's across the whole wall. The whole thing gets eaten away. So there's a GI tract here, right? And then the whole wall gets eaten away just because of one's own inflammation. And then it's deep, deep ulcerations. And guess what? They can create fistulas. So here's a anofistula. And we have a enterovistula here, right? And it go to the bladder, go to the vagina, it can go to the peritoneum and cause what symptoms? Peritonitis, right? So what diseases cause peritonitis? Almost all of them, but especially which one? If we're starting at the top. If you look over there on the whiteboard, we got which ones cause peritonitis, which ones can rupture. Definitely some peptic ulcer disease. Cancers technically they can grow and grow and grow and then perforate, right? Do hernias cause perforation? Not really. The bowel can die, but it doesn't cause perforation. But what's another one that causes perforation? Diverticulitis, right? And really, really bad diverticulosis, but diverticulitis most commonly. All right, so what else? So we have on endoscopy, they see what are called skip lesions. So you have this huge deep ulceration, but it's not continuous. So you're like skipping from one to the other. So if you're looking at it, you're just going to skip over like a cobblestone appearance. So if we look at that from the top view, this is what it looks like. It looks like a cobblestone appearance. It looks like you're going through the streets of Rome. Do you think about the Roman Empire? Anyways, we got, what else? On endoscopy, you got these skip lesions. You have nutrients that don't get absorbed. A lot of nutrients aren't going to get absorbed because you're going to fail to absorb over here and pretty much all the way down. So now you got diarrhea, and that's going to be a problem. And that diarrhea is going to start causing malnourishment and weight loss. So Crohn's disease is a really high risk for weight loss and malnourished nature. Okay, and both Crohn's disease and ulcerative colitis, they have exacerbations, meaning that they might have to go to the doctor's office or even hospitalized, and they have flare-ups. And it's usually it might be due to stress, it might be due to an infection or something. And with those, usually any kind of autoimmune disease, whenever somebody has a flare-up, what do you give them? Steroids is usually the answer. It's really hard to be on steroids lifelong. Usually on steroids, you try to cut it off at 1 month, 2 months, 3 months, right? Otherwise, you get side effects of steroids. But definitely, if you're coming in with something that's inflammatory, they're going to give you steroids to cut off that inflammatory response, right? But in the meantime, they're going to have to go home with something that's going to stop inflammation that's not steroid flavored. Okay, what else? So, more fistula. So they're going to have a lot of fistulae, a lot of fistula, compared to ulcerative colitis. All right, so this is compared to ulcerative colitis. What is unique about Crohn's disease? Because otherwise, there's a lot of overlap. Okay, like they both have diarrhea, but which one has more diarrhea? It's going to be ulcerative colitis because it's working on the large bowel, the whole large bowel. But malnourished, for sure, it's going to be Crohn's disease. All right, so you got a lot of malnourishment, B12, folate deficiency, vitamins are poor. All right, and again, you're losing blood at a slow rate, so you can get iron deficiency. And then extraintestinal symptoms. What's unique about Crohn's is the stones. All right, so stones for Crohn's. You can have this cobblestone appearance, you're going to have gallstones, and you're going to have kidney stones. Those are unique to Crohn's disease. The other things that can hit are going to be similar to ulcerative colitis. So for instance, like the uveitis, the skin manifestations, the joint problems. Both of them have that. But what is unique about Crohn's disease is the stones, right? Partly because we're not absorbing things great down here, so we're at a higher risk for developing stones. All right, so here's a skin manifestation that you get with both ulcerative colitis and with Crohn's disease. It's not unique to one or the other. All right, so ulcerative colitis. So ulcerative colitis it's the large colon, right? The C stands for colitis, or colon, right? So the colon itself is inflamed. It's usually most of the colon, but primarily likes to sit in the sigmoid area. And it's not transmural, it's just surface level. It's just at the submucosa, all right? So it's only at the very, very top layer, okay? And because of that, you're going to still not be able to absorb things because that layer is important in absorbing some nutrients. There's very little nutrients that are absorbed in the large intestine, but what is absorbed in the large intestine? Is water, right, through the whole large intestine. So we're going to have a lot of diarrhea, a significant amount of diarrhea with ulcerative colitis, right? And we destroy the mucosal layer continuously. It looks like a lead pipe. So if you light it up with a barium enema, it looks like a smooth lead pipe. It's not, usually there's little indentations all the way across, right? That has see little shapes to it, right? Look how smooth it is over here, right? So those little shapes are called haustra. So there's Anne Hostrick. Sounds like Anne Frank. Anyways, you got mucosa. It's very, very friable. What does friable mean? Like deep friable? Jalapeno poppers? Irritated a little bit. Friable means it's going to fall apart in your fingers, right? It is a very, what's the word? Fragile. There's another word for it. All right, so it's very, very fragile. So you're much, much higher risk for bleeding with ulcerative colitis. Okay, so diarrhea is very common. They're losing liters of fluid in a day. They got a lot of blood compared to Crohn's disease. Crohn's disease can have blood too, but these guys have more bloody diarrhea. They have what's called tenesmus. Tenesmus is the feeling that you're still full of stool. Like you go to the bathroom, you're like, I still got some. Give me 10 more minutes. All right, that is tenesmus, right? And colon cancer had that feature as well. All right, Crohn's disease. So what's compared to Crohn's disease? So what's unique about ulcerative colitis? It has a lot more diarrhea, a lot more blood. It has a lot more pain and tenesmus, a lot more urgency because you're right there at the rectum is involved. And what's unique about extraintestinal symptoms is you have a lot of gallbladder involvement. The other one had gallstones, but this has like gallbladder inflammation and gallbladder cancer as a risk. So complications that's unique to ulcerative colitis is what's called toxic megacolon. So megacolon is where the colon gets bigger than 5 centimeters. Basically, it's frozen at a certain point, and the rest of it just inflames and bigger and bigger and bigger until it causes a bowel obstruction, which is not good. Okay, it requires emergency surgery. Otherwise, it can perforate. All right, so these are examples of extraintestinal symptoms. All right, so you get mouth sores, you get eye inflammation, you get skin manifestations. These are not unique to ulcerative colitis. Both of them have it. But what is unique to Crohn's disease? Crohn's has stones, such as gallstones and kidney stones, whereas ulcerative colitis also affects the gallbladder, but it causes gallbladder inflammation and it causes gallbladder cancer. All right, so yeah, so there's a lot of diarrhea. All right, there's a mnemonic for what ulcerative colitis has. It has ulcers, right? It affects the large intestine, right? It's continuous. Colon cancer is a high risk. Usually within 8 to 10 years, they're going to have colon cancer. Right? They need to be surveyed with colonoscopies, otherwise they can develop. It's chronic inflammation over time. All right, so what are some diagnostic tests? So colonoscopy needs to be done to figure out what they have so we can get them on the right therapy. So usually when they diagnose it, they're going to do the colonoscopy, or when they've diagnosed it on colonoscopy, they're going to start them on medications to manage which disease they have, right? And which one has cobblestone appearance? That's Crohn's. Which one affects the colon? That's colitis, ulcerative colitis. Technically, if you look at an asterisk, the Crohn's disease can, but most commonly. All right? So when someone, and also the ulcerative colitis affects the rectum, and STDs can affect the rectum too. So they're going to do some STD testing to make sure that's not an STD. Malnourishment, they're going to make sure that there's not something else causing malnourishment, like an intrinsic factor deficit, or maybe they're on pantoprazole or something. So what else? Infectious diarrhea, because you have a lot of diarrhea. Some diarrheas out there can cause you to poop your brains out. So we have to assess if they have something another type of inflammatory bacteria, inflammatory diarrhea, infectious diarrhea. Okay. And if they have a small bowel obstruction, they might need to do some more things, but usually endoscopy or colonoscopy is going to be the way that they're going to identify. So you see all this cobblestone appearance versus a nice smooth. This one's like Anne Hostrick, right? So like Anne Heche. All right, so the treatment. All right, so really there's nothing you can do like non-pharmacologically. Basically, you have to take medications. You have to take medications that are going to stop the inflammatory process. And we'll talk more about these anti-inflammatory meds with musculoskeletal, which is actually the next exam. But a lot of these are MABs, which are monoclonal antibodies. They're specially engineered to block one specific inflammatory marker. So for instance, down here, we got this infliximab and golimumab, and it's blocking TNF-alpha. TNF-alpha is an inflammatory mediator. It's what causes inflammation. So let's go give medications that are going to stop that from happening. Let's stop the T cells. T cells attack things and they cause inflammation. We don't want to attack our bowel anymore, so let's give something that's going to stop T cells, right? And that thing is cyclosporin, for instance, right? And we have some other medications that are going to just slow down cellular division, so like azathioprine. These guys are medications that are going to just stop this overhaul of this inflammation from continuing, stopping the white blood cells from proliferating as much and causing a risk of diarrhea or dehydration from diarrhea or GI bleed, or all these things that are bad consequences or complications of inflammatory bowel disease. All right. So also there's topical aspirin, just like it's almost like PO, like taking like a PO cream, and you swallow it and you hope it makes it all the way to your rectum. And that's it's more recommended for ulcerative colitis, but you can give it for both. And it's going to be a precursor to aspirin. And it's almost like topical aspirin. So sulfasalazine, mesalamine, these are different things that are going to cause localized pain control. Steroids, when do we give steroids? When they have flare-ups, all right? That's usually the answer always with any inflammatory condition. You have something inflammatory, let me give you steroids just to shut it down. But you can't be on this forever. This is just for flare-ups, okay? And we have other medications that are just to prevent the inflammatory cascade from occurring, okay? And again, for these, I just want you to identify that this is for inflammatory bowel disease. And is it for Crohn's or for ulcerative colitis? The ones that are blue are for Crohn's. The ones that are yellow, the ones that are yellow for Crohn's. The ones that are blue are for ulcerative colitis. The other ones are for all of them, for both. Okay. So how do we fix it? You can't. All right. You can do a colectomy for ulcerative colitis, and that will stop the symptoms for ulcerative colitis, but just the intestinal symptoms. The extraintestinal symptoms are still going to remain for ulcerative colitis. They're still going to have the skin manifestations, the eye and the face manifestations, the liver damage and the gallbladder damage, right? So that's still a thing. They still have to be on medications. And then small bowel resection, so for Crohn's disease. And if they keep taking out pieces of bowel, because why would they have to take out pieces of bowel? They have fistula that form and open up and cause peritonitis and other problems. So they have to resect that piece, right? If you take out too much, you get what's called short bowel syndrome, which is a complication. And then you need to be on TPN for life. You can take oral food, but it's not going to be enough calories. You're not going to have enough time to absorb it because you keep taking out so much bowel. You don't have enough time to absorb all the nutrients. So you have to get the nutrients by TPN. And then we talked about how Crohn's disease is high risk for not absorbing B12, not absorbing folate, not absorbing iron. So you get very, very malnourished. You have to give these guys these as shots or as supplements. You could give it as PO, but it's just going to end up in the toilet because they have such bad diarrhea. They're not going to absorb it. All right, any questions? Yes?
I've seen commercials for like infusions of the monoclonal antibodies. Why do they do it as an infusion?
So a lot of usually when medications are approved, they're approved by IV form first, and then they have to switch over to PO. But yeah, monoclonal antibodies, usually when they're new on the market, they're going to be IV infusions. Does that make sense? And then they'll switch it, once they're on the market for a while, they'll switch them over to something PO. They'll get it stabilized for PO. All right, so what do we add to our man here? We have to add IBS, which is the whole thing, and IBD, right? IBD has ulcerative colitis and Crohn's. And where's Crohn's at? It's practically everywhere, right? And ulcerative colitis is just in the GI and the colon, right? All right, so let's take a break and we'll come back and do what you'd like. If you want to go over IV push or whatever, we can do that when we get back.